Hello all, this is Dr. Kaustubh Mohite, your pediatric pulmonologist. So as you must have already seen the first two parts of my lectures on community acquired pneumonia, here we move on to the third and the final part, that is the treatment. Now once it comes to treatment, it is mainly divided into outpatient as well as inpatient. So the outpatient mainly aims at giving an empirical management, whereas inpatient is specific for an organism. So the first step is always the triaging and scoring the severity of the pneumonia. Once you've done that, the second step is identifying an etiology and side by side starting empirical therapy. And finally, the step 3 is the specific management. As per the old WHO guidelines, the pneumonia was graded as no pneumonia, which involved only cold and cough, pneumonia, which involved only fast breathing, severe pneumonia, which involved fast breathing with chest and drawing, and very severe pneumonia, which had the general danger signs. However, this classification was further modified and severe and very severe pneumonia was clubbed together into one subgroup. So there are very specific indications for hospitalization of a child with community acquired pneumonia, which includes age less than 3 months, a child with hypoxemia, with saturations less than 90%, having dehydration, having inability to maintain oral hydration, who is unable to feed, having moderate to severe respiratory distress in the form of tachypnea, labored breathing, or in infants apnea, the child having toxic appearance, having comorbid conditions that may predispose to increased severity, having complications at presentation, and who has failed to show any improvement on outpatient therapy. So once it comes to neonatal pneumonia, it is broadly classified as early onset, which is less than 7 days, and late onset, which is more than 7 days. Very important to take care in case of neonates is the supportive management in the form of maintaining thermoneutral environment, maintaining adequate oxygenation and perfusion, prevention of hypoglycemia and metabolic acidosis, and also maintenance of normal fluid and electrolyte status. Empirical therapy is started till we get a specific bug causing this pneumonia. The first line of antibiotics involves either ampicillin or vancomycin along with gentamicin. So these two antibiotics, when used together, give both gram-positive as well as gram-negative coverage. The second line generation drugs mainly involve the third generation cephalosporins. Cephalosporins are specifically not used as first line generation medication, as it has been found that rapid resistance could be generated against these organisms when used initially. Once a definitive organism is found by cultures, antibiotics should be changed accordingly. And the usual duration should last for at least 7 to 10 days. For outpatient treatment in less than 5 years of age, if you have a strong suspicion of viral pneumonia, adequate hydration along with symptomatic medication is all that is required. The oseltamivir that we used is effective only when used in the first 72 hours. A suspected bacterial community acquired pneumonia is most commonly caused by Streptococcus pneumonia, and the drug of choice is only amoxicillin. With a proper dosage of 80 to 100 mg per kg per day in 2 to 3 divided doses, it should be given for a total duration of 5 days. If you have a strong suspicion of atypical pneumonia, you should directly start the child on macrolides, typically azithromycin, which should be given at the dose of 10 mg per kg per day for a total of 5 days. While treating viral pneumonia, we should be knowing the weight and age-wise dose of oseltamivir. Once it comes to the first line medication in less than 3 months, as you've already seen in the indications for hospitalization, less than 3 months should always be hospitalized. For 3 months to 5 years, the first line of medication should always be amoxicillin. If not responding to it, should be converted to co-amoxiclav or a third generation cephalosporin. If there is a strong suspicion of Staphylococcus aureus from the beginning, we better start the child on co-amoxiclav or a third generation cephalosporin from the beginning itself. Outpatient treatment for more than 5 years of age is almost similar to what is given to less than 5 years of age. However, atypical bacterial infections are relatively more common as compared to less than 5 years of age. And macrolides, when used, give a strong coverage against both atypical organism as well as Streptococcus pneumonia. However, there has been an uprise in the macrolide resistance in both of these Mycoplasma as well as Streptococcus species. This is found especially because of mutation in the 23S rRNA, which gives a resistance against these drugs. As high as 50% of Mycoplasma and 80% of Streptococcus species have been found to be resistant against macrolides. Hence, the second-line drugs like tetracyclines and quinolones should be used in such cases. Macrolide resistance have been found worldwide, and this has been published through various articles all across the world. A child with community acquired pneumonia who are treated on OPD basis should have a follow-up within first 48 hours. Appropriately treated community acquired pneumonia should show improvement within first 48 to 72 hours itself. If the expected treatment is not seen, we should better revisit the history and find if there is an alternative diagnosis, if there is a development of complication, if there is ineffective antibiotic coverage, or there is an underlying immunodeficiency. And later, the decision for hospitalization should be made for a thorough workup. Once the child is inpatient, the treatment should be mainly divided into supportive, empirical, and specific management. So supportive treatment mainly involves antipyretic and analgesics, followed by respiratory support and, very importantly, fluid management. There is absolutely no role of chest physiotherapy and nebulizations of any sort once it comes to the management of community acquired pneumonia. This point has been discussed numerous times in journals as early as 1985 by the British Medical Journal to as recent as Cochrane Library published in 2019, that there is no role of chest physiotherapy as well as nebulizations in the treatment of community acquired pneumonia. Once coming to the empirical treatment, in less than 3 months, we better start the child on both gram-positive as well as gram-negative coverage. As covered in the previous talk, we know that first year of life is when gram-negative organisms are equally important when it comes to community-acquired pneumonia. And that's the reason we add an aminoglycoside like gentamicin or amikacin in the treatment of community-acquired pneumonia in less than 3 months of age. Once the child grows more than 3 months, it's predominantly gram-positive organism, and hence antibiotics should be used accordingly. Make a note that linezolid should be reserved as it is an anti-tubercular drug and hence should be used very carefully. Specific treatment is initiated after isolating the organism from blood, sputum, bile, or pleural fluid. The duration of treatment in an uncomplicated case should be 7 to 10 days of both combined IV as well as oral medications. In case of any complications, a prolonged medication is required, which can last as long as 4 to 6 weeks or 2 weeks after the child becomes afebrile or starts showing clinical improvement. Oral antibiotics should be continued after initial IV antibiotics, even on discharge. Depending upon which IV antibiotic has been begun, if the child is suspected to have pneumonia with an organism other than Staphylococcus, you continue the child on plain amoxicillin or a third generation oral cephalosporin for a total duration of 7 to 10 days. For methicillin sensitive Staphylococcus, you can directly start with an oral third generation cephalosporin after the initial IV antibiotic course. In cases of methicillin resistant Staphylococcus aureus, we better grade up the antibiotics and can give antibiotics like linezolid or clindamycin for a total of 14 days in case of uncomplicated and a total of 4 to 6 weeks for complicated pneumonia. The parameters to be assessed at the time of discharge include all the vitals like the temperature, respiratory rate, heart rate, room air saturations, the work of breathing, chest examination, mental status, the oral intake as well as the hydration status. Important to note is that radiological involvement is not the major criteria included in assessing improvement of a child with community acquired pneumonia. Finally, we all know that prevention is always better than cure, and timely pneumococcal, Haemophilus influenza and influenza vaccine can help reduce severity as well as prevalence of pneumonia to as high as 50%. So from the past 3 topics, these are the specific take-home points that we should be learning. That specific organisms infect at specific age. One can make an educational guess regarding the type of the organism causing pneumonia based on the history, physical examination, and basic investigations. We as doctors should know the spectrum of common antibiotics we use in our daily practice. And lastly, we should have a fixed protocol of treatment involving appropriate antibiotics which will treat most of your patients. I hope all these lessons were important and informative to you for your daily practice. I'll come with more of such videos on my channel. Thank you.